Hi, I'm Aubrey Gowing, and today we're going to talk about the Piriformis Paradox. So I've been an educator for 26 years. I've been in the massage industry for about 31 years, and I've covered a wide spectrum of therapies. My main area of interest, though, for a long time has been the treatment of chronic pain. And in order to do that effectively, I'm a big believer that you have to understand the typical dysfunctions that occur within the body. The tendency for some muscles to become short and tight and facilitated, and other muscles to become overstretched, weak, and neurologically inhibited. And that's one of the things we're going to look at today as we talk about this Piriformis Paradox. So when we talk about the Piriformis Paradox, I'm going to say two things that might sound contradictory. The first thing is, Piriformis is the most overrated muscle in the body. On the other hand, Piriformis is the most underrated muscle in the body. So how do we resolve these two things? So a paradox is where two seemingly absurd or contradictory statements can actually be resolved and both be true. In this case, we would say both those previous statements are true. Piriformis is the most overrated in terms of its impact on sciatica, and then it is most underrated in one of its other functions, which is the subject of our talk today. So when we look at Piriformis, the thing that most often springs to mind for the average therapist is probably its link to sciatica. And this is shown in Google results. We Googled this the other day and we got over 1 million results when you Google Piriformis and sciatica. It tends to be a big part of our focus. And this is where I mean Piriformis is overrated, because significant neurological pain is most often when a nerve is pressed against bone. Now, I know in some cases people will talk about true sciatica, where the sciatic nerve will actually go through piriformis, and it has been shown that it's difficult for soft tissue to apply enough compression on its own to elicit the pronounced symptoms or pain that people get from sciatica. So the other is kind of a pseudo sciatica, where piriformis is pressing maybe against the nerve. And it can contribute. It is one of the factors. We're going to talk about the different factors, but Piriformis is a contributor, not the main cause of sciatica in this particular instance. So what I mean by that is you oftentimes get what's called a multiple crush phenomenon. If you get pressure in a number of places along the path of a nerve, each additional pressure adds to the severity of symptoms. Now, piriformis is far less frequently associated with what I consider to be its more important role, and this is why I consider it to be underrated, because it's actually important for stabilizing the sacroiliac joint. By comparison to Googling piriformis and sciatica, when we Google piriformis and sacroiliac, instead of seeing this over 1 million results, we see barely more than 200,000 results. We see 229,000 results, which goes to show that there isn't as much articles out there on the internet, there isn't as much awareness of it in the therapy world, and there probably isn't even as much research in its role in contributing to stabilizing this very important sacroiliac or SI joint. So let's deal with the first point. Does piriformis contribute to sciatica? Well, the answer is yes. When we look at it, there are a number of different factors that can cause sciatica. So the known things would be things like disc herniation, facet joint trouble, particularly facet joint osteoarthritis, sacroiliac fixation, and piriformis syndrome. So pronounced neurological symptoms, this is what we said earlier, are most often likely to occur when nerves are compressed against an unyielding surface, typically bone. But they are generally less pronounced where nerves are being compressed by just soft tissue. Soft tissue compressing a nerve against bone is going to cause significant symptoms. Soft tissue against soft tissue, not so much. As we said, it can be a contributor in multiple crush, but it's not a major cause. So in some people, piriformis can actually press the sciatic nerve against bone, but it's pretty unlikely. We're going to look at assessments that are going to be relevant in both cases, but let's talk about this for a second. The main topic we're going to be talking about today is SI joint dysfunction, or stabilization, which is really piriformis's role. So piriformis is underrated in its role in stabilizing the SI joint, the ilium against the sacrum during gait, in particular during stance phase, the leg that we're standing on. Piriformis has a really important role for helping to close that joint through force, what we call force closure. Now we're going to look at some assessments and we're going to look at treatment to improve muscle balance. We're going to look at why is piriformis tight when it's tight? Why is it weak when it's weak? We're going to look at what other muscles are influencing it, because we always have to bear in mind muscles don't operate in isolation. They work synergistically with other muscles. So we're going to look at what muscles caused what type of dysfunction. Why is piriformis tight in some people? Why is it weak in some people? And the fact is we have to bear in mind that it being excessively tight is bad news. It being excessively weak is also bad news. What we're really looking for is optimum tone within piriformis. So the treatment and assessment that we're going to look at is going to be equally valid and useful for SI joint dysfunction as it is for those people who are suffering sciatic type symptoms where piriformis is a contributing factor. Now when we talk about the SI joint is a synovial joint, which means that there is no blood getting into the joint. You'd be in trouble if there was. So how do the living cells within the joint, these chondrocytes, how do they survive? Because all cells need oxygen and produce carbon dioxide. All cells need food and produce waste. So how do they get their necessary raw ingredients in to perform their action and then get rid of their waste materials? So normally blood does this. Blood will bring nutrients and oxygen into the tissue fluid. The cell can then absorb that. It goes through its metabolic processes and then it excretes its waste. That waste is then in the tissue fluid. It goes into the lymphatic system and is then broken down by the lymphatics, the liver, the kidneys, and our various organs of detoxification. So within a joint, if there's no blood supply, how do the cells survive? Well, the answer is synovial fluid actually does the job the tissue fluid would do for other cells within the body. But synovial fluid is not static within our joint. It doesn't just sit there. It has to draw in nutrients and it has to take away waste. So the synovial membrane here plays a key role. The synovial membrane absorbs synovial fluid when we're resting, when we're not moving. So this helps to carry waste material out of the joint. So the cellular respiratory metabolites can be gotten rid of as that fluid is reabsorbed. It goes across the membrane and then can go into the lymphatics. But to get nutrients and oxygen in, we need movement to stimulate the synovial membrane. When the synovial membrane is stimulated, it produces new synovial fluid. So this is like the tide coming in. It brings in the oxygen and it brings in the nutrients and it feeds the living cells. So it's like a very slow inhale and exhale. So to survive, these cells have a very slow metabolic process, which is why cartilage takes so long to heal compared to a fast healing tissue like a muscle. So cartilage takes a long time to heal because its cells are moving at a slow pace because they're only getting fed and getting rid of their waste at a slower pace. So for this system to work properly, there does need to be some movement within the joint. So typically when we walk, this movement occurs that we get an on-off pressure. As we stand on one leg, we get compression. And then as we lift that leg and it's going through swing phase, we get decompression. So we get this pumping effect within the joint. This is one of the reasons why they say walking is such good exercise. So here we see the difference between form closure and force closure. For those of you not familiar with this, we'll recap this topic briefly. So in form closure, form means the shape of something. It gives it this kind of stability. I always think of like a stone arch, and supporting it in the center is what they call a keystone. When you look at the sacrum, it is acting like a keystone. The downward pressure of our body helps to drive the sacrum into place and provide stability to the pelvic girdle. That's great when we're standing on two legs, but what happens when you go to move and you're standing on one leg? Imagine again the stone arch. If you took away one side of the arch, you'd be in trouble. Fortunately, we have a mechanism for dealing with this, and that is force closure. So when we're weight bearing on one leg, piriformis acts to compress where it crosses these two joints, both the sacroiliac joint and the hip joint, where the ball and socket joint is. The piriformis is attaching to the underside of the sacrum and going out onto the top of the femur. So we see this here. The sacrum here has been made kind of translucent so we can see the nerves through it, but we can also see the attachment of piriformis on the anterior, the undersurface of the sacrum. And it's crossing out onto the top of the femur here, on the top of the greater trochanter. So when we're standing, it pulls the femur into the ilium and then pulls the ilium in against the sacrum. So oftentimes to illustrate this, I would say if you had like 3 books and you compress them together, you can lift up and the middle book doesn't drop out. Take away that compressive force and the middle book drops. So when piriformis is too tight, the joint is always compressed. It's very hard for synovial fluid to get in. There's weight bearing, there's too much pressure. The chondrocytes don't really get a chance to function properly when everything is compressed. So being overly tight is not good. But if it's overly weak, when we're standing on one leg, it can allow shift, it can allow movement, and we can end up with things like torsion patterns or upslips. And these will contribute significantly to low back pain, which will cause muscle guarding, can contribute to sciatica in and of itself, and even the ligament pattern can refer down the leg and mimic a sciatic type pain. So it's really important that piriformis does its job in stabilizing this SI joint. We're going to look a little bit at history. We talk about muscle balance a lot. So a lot of this comes back to the work of Vladimir Janda. Janda was a Czech physiatrist and neurologist, and he was one of the first guys to come up with this idea of crossed patterns. And here we see Aisling is faking an upper cross pattern. And he described these syndromes where some muscles become overused, short, tight, and facilitated. Other muscles become overstretched, weak, and inhibited. These theories have been going around for a long time. People have argued them. They've come to different realizations. The current thinking on this is that this has more to do with the posture control center in the brain stem, what we call the PMRF, or the pontomedullary reticular formation. When we get into these habitual postures, it maintains these patterns. So some of the concepts, some of the ideas behind the mechanism that Janda used to talk about has since been disproven, but yet we do still see these patterns occurring, because as people we have particular ways that are efficient for using our body and ways that are less efficient. The example I oftentimes give is you don't go into the supermarket, you see people stacking shelves like this, they don't stack shelves backwards. So as people we have patterns of muscles that we use a lot and muscles that we don't use very frequently. But some muscles don't fit into that typical pattern, and piriformis is one of those, and that's why it's important to assess. Now, Janda used the terms tonic and phasic to describe muscles that were tight and muscles that were weak, tonic being tight, phasic being weak. And our goal in treatment, I think, really needs to look at this, where we would talk about promoting muscle balance and addressing things like fascial migration, where fascia can become bound and cause a reduction in a muscle's ability to restore its normal resting length, which we'll see when we assess the hip. If there's restriction, is it that the muscle has lost some of its extensibility, as piriformis or some of the other deep hip rotators lost their extensibility? We want to reduce some of the fibrotic formations that we see. We also want to release restrictions around joints and their joint capsule. We want to restore full range of motion, which is one of the things we're going to look at, because if hip rotation is off, it will be constantly torquing on the pelvis and contributing to low back pain and muscle guarding. We also want to reduce pressure on overstretched phasic muscles. So one of the things we oftentimes talk about, this is a known concept, you should generally treat tight muscles before you can treat weak muscles. You will have very limited success if you're just targeting weak muscles. The tricky part here is that the weak muscles are usually the symptomatic muscles. They're usually the ones that are painful or causing people feelings of tension. There's many great examples of this. Hamstrings are a great example. For most people, their hamstrings are not really that tight. They are more weak and inhibited. Rhomboids are even a better example that we saw Aisling faking that upper cross posture. That tightness in the front of the body, we don't tend to feel this, we don't tend to get pain here, but we do get pain in our overstretched rhomboids. And I think in massage and bodywork and physiotherapy, we tend to focus too much on trying to restore length in the short, tight muscles, but then we don't look at really bringing the weak muscles back to their more neutral position. So we're going to look at this particularly when we get to our treatment phase. So to maintain the effects of therapy, then people need to be doing targeted home care. Now, what I mean by targeted home care is you have to establish, is this muscle tight? If when we assess piriformis and we see that we have a loss of medial femoral rotation, well then the muscle is actually tight and should be stretched. If we see that there is excessive motion, there's excessive femoral rotation, which you do see, it's less common, but you will see it. When there's excessive femoral rotation, there is weakness in piriformis. Now here's the important part. If piriformis is weak in your client and you give them stretching exercises, they will get worse, not better. On the other hand, if the problem is that piriformis is too tight and you give them strength training exercises, their problem will again get worse. So we have to accurately assess and then use accurate treatment to target those tissues, but then the last step is good targeted home care. So give people stretches when muscles aren't capable of lengthening properly. Give people strength training exercises when muscles are weak and aren't able to control motion. That might sound obvious, but you'd be amazed the amount of times I see people in clinic that are doing strengthening work for tight muscles, or they're stretching for weak muscles. Important to get those two things right. So when we look at these terms, tonic and phasic, Let's look at this a little bit more. So tonic muscles, we said, are muscles that are prone to tightness. They're short, they've lost their ability to extend properly. And there's a lot of discussion around this. Some people in the fascial world will say this is down to fascial adhesion, it's down to changes in the ground substance, it's down to excessive collagen production, this kind of fibrotic formations. And then other people in the kind of pain science field will say it's neurological. And there's probably a reasonable amount of truth to both of those statements. And certainly one will contribute to the other, because if you have fascial adhesions, it becomes a neurological habit, and you will then have both a fascial and a neurological outcome. If you have a neurological tendency, that will then allow the tissue to bind up, and you will have a fascial restriction as well. So I personally think the two of those go hand in hand. With weak muscles, the fascia tends to be overstretched, weak and inhibited, which places a lot of load on it. And that constant load, whether it's on a muscle, a tendon, or a ligament, will cause pain at some point. It is dysfunctional. So it's important to unload those tissues. But as we said, we can only do that once we've treated our tight muscles. So let's take a look at an example of some of these. So examples of tight muscles would be things like quadriceps. Here's where I differ with a lot of other people. I would tend to find from clinical practice, glute medius and minimus actually are short and tight. And the adductors on most people are weak and inhibited. Now that person may have restricted range of motion. When you go to stretch their adductors, they may have limited motion. And I think that's more down to fascial adhesion, because those muscles, when you test them, will oftentimes test as weak. The adductors will be restricted in their motion, but they'll also be neurologically weak. So my concept, my idea of muscle balance is that glute medius and minimus are actually short and tight, and the adductors tend more likely to be weak and inhibited. In some cases, I think in forward motion, these things are much more predictable. Quads are always going to be tighter than hamstrings. I don't think I've ever seen a client the other way around. Whereas with lateral movers like the abductors and the adductors, it's less predictable, but there's still a predominance. There's a majority that you'll tend to see. Tensor fascia lata is one of those muscles that's predictably tight in most people. But remember, it does 3 different movements. So it's mostly its flexor fibers that tend to be tight. And this is why we again need to assess rotation. Piriformis and the deep hip rotators are more likely to be tight, but you will see clients with weakness. So again, because of these lateral motions as opposed to linear motions, we will oftentimes see less predictability, but there will still be a majority, a tendency that we'll see time and time again. The weak muscles will be things like the proximal portion of the hamstrings. I have my own sitting theory where I would say, if you look at the position a muscle is in when you're seated, that tends to indicate its typical dysfunction. And this is particularly true around the pelvis and into the legs, because our hip flexors are in a shortened position, and when you test them on most people, they have reduced ability to lengthen. Muscles like our glute max and the proximal end of our hamstrings tend to be in a stretch position, and so they tend to be stretch weak. The distal end of the hamstrings is slightly different, because most people will bend their knee when they sit down, so the distal end is oftentimes short and tight. And that's why I'm distinguishing here and saying the proximal portion of the hamstrings is most likely to be weak and inhibited. The adductors, again, sometimes you'll see this the opposite way around in some texts, but from clinical experience, my findings are that the adductors have a tendency to actually be weak, even though they may be fascially restricted. Glute maximus then typically is going to be weak in most people. Vladimir Janda, this is one of his earliest findings when he was coming up with his crossed patterns, where he said you have weakness going one way through glute max and into the abdominals, and then tightness going through the hip flexors and into the low back muscles like quadratus lumborum and the lumbar portion of the erectors. And he said that in most people, glute max was going to be weak and inhibited. That was one of his first clinical findings, that people with back pain, a huge proportion of them had tested weak for glute max. I like Eric Dalton saying this. He says, you know, if your back hurts, it's your butt's fault. But I always say, be careful not to say to people, you know, it's your lazy ass is the problem. Not true, not nice. But it does have a tendency to be weak and inhibited. Piriformis and the deep hip rotators, you can see this is in both categories because it's less predictable. So this is why assessment is particularly important rather than making assumptions. The last point I would make on these is that with our tight tonic muscles that are prone to shortness and tightness, the correct home care is to try and stretch them to restore normal resting length. For the muscles that have a tendency to be weak, we need to neurologically stimulate them. We need to do strength training to restore tone for these muscles. So the muscles that are in the tonic tight category definitely require stretching. The ones that are in the phasic category will require strength training. And the reason I mentioned that several times is because it really is important. There are some gurus within our industry who will say, stretch, stretch, stretch. Everything is about stretching. And they're right, about 50% of the time. The tight muscles need stretching. There are other people who almost exclusively say strength training. Strength training is the most important thing. You have to strength train everything. And they're right about 50% of the time. If you're dealing with muscles that are weak, they do need strength training. So we do need to marry these two concepts. We need to make sure that we are stretching muscles that are tight and strength training muscles that are weak. So let's take a look at some assessment then for this rotational pattern within the pelvis, and then we'll take a look at some treatment. So now we're going to look at some passive femoral rotation to assess range of motion, but also to determine end feel. So when we're rotating the femur, we're going to bend the knee from this prone position, and we would expect the femur to have available to it 45 degrees of medial rotation and 60 degrees of external or lateral rotation. So when we bend the knee, we're going to stabilize the pelvis, and we're going to let the foot drop out. Now remember, as the foot is dropping out, the patella is turning in. So this is actually internal femoral rotation. And we would expect to have 45 degrees of rotation, which we pretty much have. We have 45 degrees. And we should have a little bit of what's called accessory motion, a little bit of stretch just beyond the 45 degrees. It shouldn't feel abrupt. So we've got pretty good internal femoral rotation on the right side. When we go the other way, we should have 60, and we're stopping short of that. So here's 10, 20, we're maybe getting to 30, but the end feel is quite different. Watch this hand. The pelvis will start to move with the femur. So this we would describe as a bone-on-bone like end feel. It's not true bone-on-bone. Bone isn't actually hitting bone. We're not hitting an anatomical barrier. Instead, what we're encountering is a capsular restriction. So there is some joint capsule restriction that's preventing that motion. If it was tight muscles, we would still have a tissue stretch, soft end feel, whereas this is quite abrupt, so we're thinking capsular. That makes a difference because we're going to treat differently. We may need to do a capsular release. We'll reassess as we go through treatment. Let's take a look at the other leg. So again, we're flexing the knee to 90 degrees, stabilizing the pelvis. We expect 45 degrees of internal femoral rotation, which we pretty much have here. And again, a little bit of accessory motion. Sometimes it's not that easy to tell. It's slightly capsular, slightly tissue stretch. That's what it feels like on this side. And that usually means there's a little bit of both. So sometimes as we stretch or do a muscle energy technique for the tight muscle, the capsular restriction becomes more evident. So don't be surprised if the end feel changes as you go through treatment. Let's try the external femoral rotation. So the patella is turning out as the foot is dropping in, and we're meeting restriction quite early here, so maybe at 20 degrees. And again, watch for the pelvic motion. See how the pelvis starts to move? There isn't independent motion between the femur and the pelvis. The pelvis is starting to roll with it. So again, this is a bone-on-bone-like end feel, indicating a capsular restriction. So prone assessments check with the femur in a neutral position at 0 degrees. This engages just one portion of the capsule and checks just some of the fibers of the deep hip rotators. So next, we're going to check from a supine position where we'll be able to alter the angle at the hip, changing the position of the femur and seeing how this changes our assessments. Now with the client in a supine position, we're going to check those same assessments of medial and lateral femoral rotation on each side, and we're going to check them at different degrees of hip flexion. So first of all, we're going to check at 45 degrees. And this doesn't tend to be as problematic. So let's bend the knee. We're getting the femur up to 45 degrees, and then we're going to go through lateral femoral rotation, which should be 60. And you can relax the leg from here. Let the knee drop. There, we've pretty much got 60. Slightly bone-on-bone-like end feel. So although we have full range of motion, I wouldn't be entirely satisfied that there isn't some dysfunction within this side of the hip at 45 degrees. Now we're going to go through medial femoral rotation. And we have 45 degrees. And pretty much a tissue stretch end feel. Let's take this up to 90 degrees now and see, does this change? As we let the femur come out, we're expecting 60 degrees and we're stopping short of that. Again, we probably have about 50 degrees and a capsular kind of end feel. It feels quite abrupt. Then we're going to go through medial femoral rotation. And again, we see more restricted. So if we look at the difference here at 90 degrees, we've got maybe 20 degrees of internal femoral rotation. If we take the hip flexion down from the 90 degrees to about 45 degrees, we see how the range of motion changes. We have full range of motion. So there is a difference in different parts of the capsule. Not all of the capsule is dysfunctional on this side, but it becomes evident at 0 degrees and at 90 degrees, but is less evident at 45 degrees. Let's do a comparison with the other side. So again, we're going to flex the knee, flexing the hip to 45 degrees. We're going to go through our external femoral rotation, checking the range of motion, and we're almost 60 degrees, but again, a slightly capsular end feel. When we go the other way, we have 45, and it's mostly tissue stretch. I'm watching that pelvis. Yeah, if we go a little further, you can see the pelvis starting to rock. So again, we might have a little bit of both, a little bit of muscle restriction and a little bit of joint capsule restriction. Let's take it up to 90 degrees. And again, we're going to go through lateral femoral rotation, expecting 60 degrees, and we have about 45 with a capsular bone-on-bone-like end feel. Then we're going to go through medial femoral rotation. We're expecting 45 degrees, and we're getting maybe 20, 25. We could measure these precisely using a goniometer. For speed and convenience, because we don't need to be accurate to within a degree or two, I'm quite happy to use this by eye. But when you're practicing, if you're not sure of what a degree is, a goniometer can be a useful tool to improve the accuracy of your assessment. So in terms of treatment, we're going to start off with TFL in most cases, because we generally want to treat tight muscles before we treat weak muscles. In Emma's case today, she does have some tightness in piriformis, so it wouldn't be as relevant, but typically it's going to be TFL we're going to treat first. So TFL, or tensor fascia lata, is a small muscle on the outside of the hip, and comparatively complex because it does 3 different movements. So it is involved in abduction, it's a medial rotator of the femur, and it's a hip flexor. And it's the fact that it's usually shortened when we sit that causes this muscle to be predictably tight in most people. To locate this, we're going to feel the iliac crest, work our way forward until we feel the ASIS, and TFL is going from ASIS back about 2 inches or 5 centimeters back along the iliac crest, and then angling down towards the greater trochanter. To find the greater trochanter, we can press below the ilium, work our way down until we feel a bony prominence here on the outside. Now, if we draw a diagonal line between the greater trochanter and the iliac crest, we'll be able to determine the line of TFL. Here's another simple way of making sure we're on the right muscle. When we suspect we're in the right area, we're going to put our fingers over the area of the muscle and we're going to call for movement. So in this case, Emma, can you try and turn your knee in on this left side? Good, and we feel the muscle contract. So that tells us exactly where TFL is. You could even have the client hold that position for a moment so you can feel the posterior border and the anterior border if you're unfamiliar with this muscle. And you'll find it's about the size of our closed fist. So this area of the first phalange with the closed fist is going to cover all of TFL. So I'm going to use that to hook in just below the iliac crest, and I'm going to draw the tissue down a little bit. Now, if this is tight, sensitive, or ticklish, I can start to reduce some of that sensitivity by just pumping the tissue. When I pump, I'm going to compress firmly enough to meet resistance, but not cause any pain. When I ease back, I allow for capillary refill, and then I compress again. So partly we're overriding some of the mechanoreceptors, we're stimulating them a lot to reduce any sensitivity. Partly we're encouraging a tissue fluid exchange in the area, and the combined effects of these means less sensitivity. Any discomfort or soreness? No. So as we pump, usually after about 15 or 20 seconds, you'll notice that the muscle starts to soften a little bit, or the client will report that the sensitivity or ticklishness was gone, where this wasn't sensitive to begin with. We're more feeling for a change in the texture of the muscle. So we're feeling that soften now. So now I'm going to draw down because I'm trying to lengthen this muscle, and I'm going to passively turn the leg. I would do active in some cases, but here TFL just contracts too strongly. We'd be pushed out of depth, and we would no longer be down in the dysfunctional portion of the muscle. I'm going to turn for about 10 seconds, and then I'm going to go back to pumping. Pinning down, and small turning motions. Pump and stretch. And then we can start to go cross fiber. So I can hook in and just see. Now I can feel some tight bands going this way, which indicates that it is TFL. Any sensitivity? A little bit. So what we want to determine is how sensitive. So on a scale of 1 to 10, could you give me an estimate of a number that you'd put on that as we twang across?
5.
5. 5 is a little too much. I want to keep it at a 4 or less. And we would define this as mild discomfort, that the person is still staying relaxed. There's no change in the breathing pattern. There's no tensing or guarding. There's no widening of the eyes. So it's not just about what they say, it's also their reactions. So we're going to reduce the intensity, reduce the pressure a little bit. How's that now?
Yeah.
Is that more like a 4, 3?
Yeah, 3.
3.
Yeah.
Okay. So again, I'm going to go into that sensitive area now. I'm using a small surface area, so this is going to be more intense than when I was using the broad surface area at the back of my knuckles. And I'm pumping specifically on the group of fibers that feel tightest within TFL. I'm going to pump and then stretch down. Pump again. And usually I will repeat this pattern of pumping and stretching about 3 times and then go back and reassess the sensitivity. So this is our 3rd time pumping for 8 or 10 seconds or until I feel tissue texture change, and then stretching down a couple of times, or I could add a little bit of movement to this, lengthening as I externally rotate the femur. Now, that's the same pressure. What's the intensity like?
It's fine now.
It's fine, okay.
3.
3. So we can go in a little stronger, and at this point we may encounter some trigger points, a little sharper there.
Yeah.
Scale of 1 to 10?
4.
4.
It's fine.
Perfect. If it was a 5 or a 6, I would go back to just pumping right on this trigger point for about 10 seconds and then go back and reassess, and it should have dropped significantly. Here I'm just holding a static compression for about 10 seconds, or again until I feel a softening, a change in the texture of the tissue. How's that now?
It's fine.
Is it reduced?
Yeah.
Okay, can you put a number on it now?
2. 1.
1. It's still going down?
Yeah.
Okay, we'll give it another couple of seconds. If it plateaus at a 1 or a 2, I'm going to work this trigger point again, or rather I'm going to work the next trigger point down. Oftentimes we have clusters of trigger points in the one area. How's that now?
It's fine. It's gone.
Gone. Okay. So I'm going to pump and stretch, because trigger point theory would tell us trigger points form because of ischemia. So pumping helps to deal with the ischemia, but there can still be localized fascial restriction that could restore that ischemia quite quickly. So once I've pumped, I want to stretch out those tissues, and I feel another tight band just underneath, and what feels like a little nodule, another trigger point, another sensitive spot there.
Yeah.
Is that on it or not quite?
I
think we slipped off it.
Yeah.
Yeah. That more like it?
Yeah.
Yeah. We see the difference in the client's reaction. Scale of 1 to 10.
5.
Okay. Started as 5. Is it dropping already?
Yes.
Yeah.
Yes.
Okay. If it's a momentary 5 and the person doesn't seem too distressed, you could see for the first second, Emma did have a slightly startled response, but it changed very quickly. So I'm happy to continue holding. But if it was a 5 and they're starting to tense up, that's when I'd go back and pump. How's that now?
It's gone, and maybe 1 or 2.
Is it still reducing?
No. Yes. Yes.
Trigger points can be tricky. It is a unusual neurological sensation, so sometimes it can be hard to categorize. Okay, we're going to give that a little pump and stretch. Now, there's 2 different techniques we can do here that look very similar. So one is a soft tissue release where I shorten the muscle, lock away from the restriction, and then lengthen. And this can be a little intense. Is that okay? Because we're just using 2 fingers. If I use more fingers, it's less intense. You feel the difference?
Yeah.
Yeah. Not as pinpoint, but that could be a good thing if it's too intense. So I shorten, lock away from the moving joint, and lengthen. Shorten, lock, and lengthen. To restore length, I could go the other way, where I pull down as I lengthen. This is going with it. And this is more like a pin and stretch, that I'm pinning the tissue away from its origin here as I lengthen. This is less intense because I'm going with the movement of the tissue. The STR is more intense because I'm opposing the movement of the tissue. Stronger technique, but more intense and sometimes not as well tolerated. Okay. I would repeat that on the other side. So hooking in with the backs of the fingers. And by hooking in, I just mean grip the tissue, draw down away from the pelvis to begin with. Pump, stretch, mobilize. We might even hold the position and pump for maybe 10 seconds. So intensity is not a bad thing in a treatment. We want some intensity so that we're going deep enough to cause change, but we don't want too much intensity that the client is in pain and starting to guard. One of the things we're trying to achieve is to bring good news to the brain. We're trying to have the nervous system communicate positive information during a treatment session so that we get a strong psychological effect from our treatment as much as a physiological effect. If you put your client through an hour of pain and when they're on the table, the nervous system is not happy. That has a negative impact on treatment outcomes. We can pin and stretch, or try the more intense soft tissue release, shorten, lock, and lengthen. How are we doing on that one, Emma? It's okay. Mild discomfort? Yeah. And again, we would assume that because looking at facial expression, looking at body language, she's not particularly flinching or tensing up. She's not trying to pull away. She's not showing any signs of distress in her face, like either widening of the eyes or frowning, any of those signs that might indicate that the intensity is starting to climb too high. We're going to go cross fiber again, which is going to be a little bit more intense. Any discomfort?
No.
We do feel 1 or 2 tight bands, so we think there might be a trigger point in the center. That it there?
Yeah.
Okay, a scale of 1 to 10? 7. Too much. Let's pump. She's very calm for a 7. A lot of people, when they say 7, it's like, 7. So again, listening to how your client communicates, their pitch of their voice, their breathing patterns, have those things changed? So here we're using an on-off pressure, so it'll feel a little bit more sensitive, a little bit less. But we're getting the mechanoreceptors used to this. We're stimulating a lot of those nerves and helping to create a neural gating response, dampening down the pain signal that the brain is getting. And now we're going to go back to that same trigger point. Scale of 1 to 10.
2.
2. Okay, so I think we might not be quite on it. How's that there?
It's fine.
Still like a 2 or 3?
Yeah.
Okay. So we're going to hold for about 10 seconds, and we would expect to see a reduction. We'll feel an easing within the tissue, and we would expect the client to report less sensitivity, less sensation in the area. Okay, how's that now?
Yeah, it's gone.
Gone completely.
Yeah.
Okay. So let's reassess what our range of motion is like and what our end feel is like. So it was the 90 degrees that was a little bit more dysfunctional. So let's go up to 90 degrees. I always think it's really important to reassess during treatment because your initial assessment is only giving you an indication. As you treat, those indicators can change, and as a result, we need to modify our treatment program. So when we rotate, we've pretty much got full range of motion. Still feels a little capsular. We haven't done anything for piriformis, so I wouldn't have expected this to change too much, but still feels a little capsular. So I've got a couple of different options here. Firstly, I'm just going to try a compression and decompression. Because I want the client to be passive, I'm going to rest the client's leg on mine, and I'm going to use this kind of axial driving force just to gently bring the head of the femur into the socket, into the acetabulum in the pelvis. It's not very forceful. If I start to use a lot of force, the nervous system will actually start to guard. What I'm trying to do is bring the bones together in such a way that the nervous system feels it doesn't need to support. So the muscle guarding will relax, and we should be able to give a little bit of a stretch to the tissue surrounding the joint. What I'm feeling for during this process is these subtle signs of the nervous system moving into its relaxation parasympathetic responses. So you'll feel these very subtle reductions in tension under the fingers and palms of your holding hands. This is an unusual technique because you really have to be patient. You have to take your time. It's not something you can rush. You're just waiting for the client to respond, and it's a subconscious thing. It's not something that they can assist you with or that they have any conscious control over. After a certain point, you'll feel things are nice and relaxed, and it feels like the bone is nearly just floating in the socket. It's a subtle and subjective experience, but if you are patient and you hold the client in this position, you will feel those changes. So now we're going to switch from compression to decompression. Very easily done here. I'm just going to slide my support up a little bit, stabilize the leg, and just lean back. So I'm slightly drawing the femoral head out of the acetabulum, out of the socket. Any discomfort? No, should feel like a nice comfortable stretch. I'd always ask because sometimes it could be moving something in the low back. It could be causing a little bit of discomfort. Let's repeat that, totally relaxed. We're just going to get a little bit of axial load down through the femur, bringing the bones together and just holding and waiting for the nervous system to let go. So when it's mostly neurological in nature, this will oftentimes be enough to release a capsular restriction. Sometimes we'll have to progress on to a stronger technique, which we'll demonstrate now in a moment after we reassess. That feels nice and relaxed now. So I'm going to switch from compression to decompression once again. Notice how I'm not working hard. I'm using my body weight. I'm just leaning back, drawing on the femur, helping to decompress from the acetabulum. This is also very good for clients who have labral tears. Let's reassess before we go on to do our stronger capsular release. Feels less obviously capsular, but there's still restriction there. Okay. So now we're going to use the femur to massage the joint and mobilize the capsule around the socket. So I'm going to gently compress, rotate, and decompress. And the client stays totally passive for this, which we're doing, which is good. Compress, rotate, and decompress. This is a technique developed by James Waslowski, so I have to give Jim credit for this. Any slight changes that I'm making is down to my technique, not Jim's. And now we're just going to stretch through and come back. Okay, and reassess. Now we're getting further, and we have a slight muscular restriction. So this time we're going to switch to muscle focus, and we're going to do an MET. So I'm going to try and get you to swing your heel gently towards your left shoulder. So pulling your heel around, you're going to try and swing the leg this way. So just gently pulling, not too strong. Go a little stronger. Good. Any discomfort with that?
A little bit, yeah.
Okay, where do you feel that? On the outside of the hip? Okay, relax for a sec. We're going to change, back it off a little bit, pull again and see, does that help?
Yeah.
Okay, no discomfort now?
No.
So we do have to pay attention to the client's responses and modify accordingly. And relax, deep breath. Exhale, now try and bring the foot out towards me. Go in the opposite way, yeah, good. Gently pull in. How are we doing, any discomfort?
No.
Good. Because every time you have the client resist like this when they're doing an MET, you are doing a muscle resistance test. You're assessing the muscle, its tendon, and its attachments. And if there's any tear, any old strain injury, you may have to stop and treat that before you can continue. And relax, deep breath. Exhale and see if you can bring the foot out towards me. And we have 45 degrees of internal femoral rotation. Now we want to reinforce that for the nervous system. So now we're going to move into some active isolated stretching. Try and swing the foot towards me. Good. And relax. Swing the foot towards me. Good. Any discomfort?
No.
No. Okay. Swing the foot towards me. And I'm only very gently assisting. It's important that the client does all of the work here. You're only very slightly assisting at the end to get that last little bit of accessory motion. The reason it's important that the client does the work is they are in the process of retraining their nervous system. If you do all this for them, their nervous system really isn't making much adaptation. Is that okay? Now let's check range the other direction. Okay, so this time you're going to try and bring your foot towards your shoulder and let your knee drop. Relax. Good, back to neutral. Foot towards the shoulder. Let the knee drop. Good, and relax. Foot towards the shoulder. And relax. Foot towards the shoulder. Let the knee drop. Good, relax into it. Any discomfort?
No.
No. And we have 60 degrees of rotation. So we've now restored proper rotation in both directions. Doesn't necessarily mean our job is done because that's at 90 degrees. So now we're going to turn the client face down and we're going to reassess. Don't be surprised if you see the dysfunction resurface. It's because we are now stressing or testing a different aspect of the musculature and a different part of the joint capsule. Now with the client in a prone position, Let's reassess the same right leg that we worked with the client supine. So we're going to bend the knee to 90 degrees, stabilize the pelvis, and we're going to let the femur go into internal femoral rotation. And we have 45 degrees, tissue stretch end feel, feels pretty good. Let's try the opposite direction, which was restricted, and is restricted again. Now again, this to me feels capsular. Even though we had full range of motion supine, that was with the hip flexed to 90 degrees. With the femur at 0, we need to retreat after we've reassessed. So let's take a look at how we would do the same capsular work now with the client in a prone position. So this time, instead of holding the leg, I'm going to let the table do most of the work for me. I'm going to push the leg up towards the client's head, but I'm only going to do that until I feel a subtle stop where the bone is meeting bone, the femoral head is meeting the acetabulum. If I push too hard, again, I'll kick in neurological guarding, and I'll know this that I'm pushing too hard because I'll start to see the pelvis lift on this side. So I'm going to take a hold of the thigh, leaving the weight of the leg on the table, and I'm just going to gently push up. Now I'm starting to see the hip lift, so that's as far as I'm going to go. And once again, I'm just going to hold. Now this can take 30, 40, or even 60 seconds. So it's really important to be patient and wait for change. 60 seconds can be a long time in treatment without anything happening. So it's oftentimes a good time to engage your client, explain to them what's going on. So basically, Emma, what we're doing here is bringing the bones close enough together that the nervous system decides that the muscles don't really have to do very much, and it lets them relax. Once they relax, we can move the hip capsule a little bit better. So we're just waiting for that relaxation process to kick in. Or you could do a little bit of visualization with your client. You could say, just turn your attention to your quads for a sec, Emma, and just imagine your quads just relaxing. Imagine like you just flick a switch and they let go and relax. Turn your attention to your hamstrings. Again, feel for any tension and decide to flick a switch and let them relax. Same for the adductors. Relax. The muscles around the hip, relax. Even the muscles in the low back, just decide to let them relax. Now I can feel a subtle letting go within the musculature of the thigh. So now I'm going to decompress, stretching down, mobilizing, and we're going to go back to that same position. So we can see just as soon, if I keep pushing, we see how the hip rises. So I'm just going to bring the bones together just until I see the hip begin to rise. I'm going to hold again, waiting for that relaxation effect to kick in, waiting for the subtle letting go that I'll feel in the musculature. Happens pretty quickly this time. Just wait for that to relax a little bit more, and then we can decompress. Let's reassess. Checking the rotation. Still good on internal femoral rotation. External, a little restricted. Look at the hips starting to rise. We see here. So now I'm going to do the capsular work by rolling the thigh. So I'm going to get in under the thigh. And again, Emma, you can stay totally relaxed. I'm going to bring the bones together, turn the femur until I feel a little bit of restriction, and come back. Bring the bones together, a little bit of rotation, and then draw down. And this is subtle. I don't want the person complaining of any kind of sharp pinching or anything in the low back, that it is just working into the hip socket. Again, the weight of the leg is on the table, so I'm not really lifting the leg. I'm just guiding it up and down and rolling it through rotation. And once I feel that it's moving a bit easier into lateral femoral rotation, I'm going to try and stretch through the restriction and decompress. We see some increase, and now it's muscular, so we're going to switch to an MET. Emma, can you just push back at me with your ankle? Good. Any discomfort? Yeah. Good. And relax, deep breath. Exhale and try and let the foot fall across. Nice increase. Push back again. 2, 3, 4, 5, 6, 7, 8, 9, 10. And relax, deep breath. Exhale and let it go. And we have 60 degrees of rotation. So by playing back and forth between this muscle work and this capsular work, we should quickly and easily be able to restore full range of motion to both internal and external femoral rotation. So now we're going to take a look at some treatment for piriformis. Bear in mind that in most people, glute max is weak, so we don't want to do a lot of massaging through glute max and relax it even further. We will do a spindle stim technique towards the end to see if we can stimulate tone and wake this muscle up. But when I go to work piriformis, really what I'm going to try and do is work the attachment at the greater trochanter and just beside the edge of the sacrum. I can't get underneath the sacrum to work that actual attachment, but I'm going to get the muscle tendon junction or in that vicinity quite well. So I'm going to palpate again, coming down from the pelvis, feeling the top of the greater trochanter, and I'm just going to work around that and see, do I feel any tight bands, which I do a little bit there. Any sensitivity on that, Emma?
Yes.
A little bit on a scale of 1 to 10?
6.
6, okay, that's a little too much. So let's go back to our pumping. Anytime we encounter that excessive or severe sensitivity, if we will just take the time to pump, to stimulate the mechanoreceptors, to get some fluid exchange going, will actually help to reduce the sensitivity. And then we can continue to do the same work without the negative, either psychological or neurological effects. How's that now?
Yeah, it's fine.
Less sensitive?
Yeah, it's
okay. Gone.
Yeah.
Okay. So now we're going to introduce a new level of intensity by bringing in some movement, where we're pinning the tissue and stretching. How's that?
Yeah, it's sharp.
Sharp, just at the end there?
Yeah.
Yeah. So again, we're just going to play around just where it starts to get sharp. I'm holding the tissue and just, I can feel the tissue texture change. It's nice and smooth, and just there, it starts to change. It's at that edge that I want to just start introducing some pressure to those mechanoreceptors, start getting the nervous system used to this kind of pressure and deciding that it's not a threat, mitigating those nociceptors, reducing that threat signal coming into the brain. Has the intensity on that now?
Yeah, it's fine.
It's fine.
There's nothing.
Okay. So now we're going to move to the other attachment, or the muscle tendon junction here. So again, if we start off at waist level and we come down onto the sacrum, drop just laterally off the edge of the sacrum. A little bit of tightness just there. How's that feeling?
Yeah.
A little sensitive? Okay. On a scale of 1 to 10, can you put a number on that?
4.
4. Okay, 4 is okay. We can work with a 4. So let's introduce some movement again. Bending the knee, rocking back and forth as we pin those tissues. That's still okay?
Yeah.
A little bit of sensitivity?
Yes, like 2 or 3.
2 or 3, yeah. Because again, we could hear a little bit of hesitation in your voice that we're thinking, there's some intensity there. Not too much, but there's some. 3 or 4 we can work with. Now, I'm starting to feel that soften. The tissue is starting to relax. Is the intensity reducing?
Yeah.
Okay, what's that at now?
It's gone.
Gone, okay. So next we can look at some trigger points in piriformis. Now, Leon Chato came up with a very good way of triangulating and pinpointing where the muscle belly is going to be, and thus where the central muscle belly trigger points in piriformis are likely to be located. If we feel the ASIS, the PSIS, the greater trochanter, and we estimate where the coccyx are, and we draw a line between those, that should be right in the center of piriformis. Anything there?
Yes.
Okay, scale of 1 to 10?
6.
6. Okay, 6 is too much, so we're going to pump a little bit. So each time we pump, we're going right down till we feel some resistance within the tissues and letting go. A little bit of resistance and let go. A little bit of resistance and let go. There's no point pumping tissue that's already relaxed. Each time you have to go down through the relaxed tissue and feel where the restriction is and pump at that particular depth. And then when we're doing something like trigger points, being in that precise location so that we're affecting where the trigger point was housed. Now we press again. How's that, Emma?
Yeah, it's fine. It's gone.
Gone?
Yeah.
Okay, so I suspect there's another one in the vicinity. How's that now?
Yeah, that's after going up now.
Okay, what number are we at?
5.
About a 5. Is it tolerable 5? You know, already I can feel it starting to respond. So
Yeah.
Is it reduced already from a 5?
Yeah.
Okay, so this is what we mean by a momentary 5. If the intensity spikes for just a second, which it often will with trigger points, particularly in sensitive areas like subscapularis or piriformis, I'm not too worried about the spike. It's more what's it going to be like for the main duration, for the kind of 10 to 12 seconds that we're holding. And if it's going to be a 4 for most of that time, I'm happy enough to continue to hold. How's that doing now?
I'd say 2.
2, still reducing?
Yeah.
Okay. If it's still reducing, I'm still going to hold. If it's plateaued and it's really not changing, then we're thinking we're actually pressing slightly on the next trigger point down. So that to me feels like it's softened quite a bit, but I'm still going to give it another 1, 2, 3. How's that now, Emma?
Yeah, it feels gone completely.
Gone completely. Okay. Pump. And stretch out the tissue. Okay. So our last section then is going to look at home care, appropriate stretching or strengthening depending on what we assess at the end of our treatment session. When we check the rotation, we would say we're optimal. When we're rotating this way, we're a little bit restricted. So we're going to give the client some stretching for TFL. And because she was inclined to be a little bit excessive, I'm going to give her a strength training for piriformis, which is slightly different to what we saw at the start, because at our assessment at the start, I would have said we probably needed to stretch, whereas now, reassessing at the end, I would say strength training is going to be more important. So we see why it's important to not just assess at the start of the treatment and then work on that as an assumption going forward, that we should always be moving smoothly between assessment and treatment with each technique that we perform. And then reassessing at the end of treatment, both to evaluate our treatment outcomes, but also to evaluate change and modify our program accordingly. So now we can look at stretching or strengthening for TFL or piriformis. So when we go to do strengthening exercises, we need some resistance. Resistance can come in a couple of different forms. Probably the easiest is to use something like a power band, because this being a continuous loop, we can very easily make almost like a noose for the foot to go in. You could use an ordinary TheraBand and just tie a knot in it, but this is a little bit quicker and easier. These come in a variety of strengths, so we want to make sure that we're using one that's strong enough but not too strong. This one looks quite light, but piriformis is a small muscle, so it doesn't need to be very strong. So we're going to make that loop just by taking hold of the band, reaching through. Now we have a loop to put around the foot. So we're going to bend the knee. That's good. Thanks, Emma. So we're going to loop this around the foot. And what we're going to do for our strength training exercises, we're going to have Emma hold this. And she's going to hold it quite low down by the table. Now, ideally, we want to try and bring the foot out. So just let that slide through your hand. Good. And now hold there. And you're going to try and pull the foot in. So you're activating piriformis. So one movement is a repetition. And we want her to be able to do about 10. That's 2. Good. 3. Now, see the way it's kind of twisting your foot? I'm not that happy with that. So let's change the position. And I'm just going to come down onto the ankle. Make sure this is comfortable enough. Is that okay? Let it come out a little bit more. So let it come fully out. Good. And now pull in. A bit tougher. Yeah. See, clients will do all these things to make life easier. Okay. 8. How are we holding up? It's okay. Getting tough. 9. You feeling a bit of burn? Okay. 10. Good. Okay. And relax. It's good. So ideally, we would want the resistance to be enough that the client can comfortably do 10 repetitions. And ideally, we'd want to build them up to about 3 sets. But you're probably better initially, when the muscles are not yet accustomed to this, start them on maybe 6 reps. I want to make sure they can do 10, but I'm going to start with her doing 6 reps twice. So she's going to do 6 reps, take a rest for about a minute, minute and a half, and then do another 6 reps. Within a couple of days, that will get easy, and she can add another set. So she'll do 6, 6, and 6. When that gets easy, she can do 8, 8, and 8. When that gets easy, 10, 10, 10. When that gets easy, we need to go up in strength. We need more resistance. Stretching then is the other side of this. So in this case, we're going to have Emma do a stretch for TFL. Stretching does not use resistance. So we need something solid. We're going to use a stretch rope. There's a lot of different styles of these. You could even have your client use a towel. Again, I'm going to make a loop. And I'm going to put this around the foot. And this time, to stretch TFL, what I'm going to have Emma do is she's going to actively try to bring her foot down towards the back of the opposite knee. And then the rope is just going to be added at the end with just a couple of pounds of pressure. You don't pull through because then the muscles aren't being retrained. So we're going to bring this hand down by your side. Again, we want it to be low, not up by your shoulder. You're going to start off in this kind of neutral position. Now, without pulling on the rope, bring your foot down to this knee. And only at the end, give yourself a little bit of help. 1, 2, and back up to neutral. Bring the foot across, only guiding with the rope, and then a little bit of pull at the end. Good, for another 2 seconds. So that's up to 4 seconds. We're going to go to 20. Bring the foot across. 5, 6, good. Keep the hip on the table. Bring the foot across. Good, 7, 8. And across again. 9, 10, good, back up. Try and keep that hip down. Good. 11, 12, good. And this can be done on the floor. They don't particularly need to do this on a bed or on a couch or anything. This can be done on the floor. So you're going to keep going. Each time you get to the end range and you're just adding a little bit of pressure with the rope, you just hold for 2 seconds and bring it back. And you're going to count in 2s up to 20. If you feel like the client needs more assistance or you believe that stretching should be done for 30 seconds or a minute, you can go longer, but just do it in 2-second increments. Okay, last one. And back to neutral. That's good. Any problems with that? Any discomfort?
No.
No. Okay. If we were restricted in medial femoral rotation and piriformis was tight, we would do the opposite. So the rope would be here. And again, we would have Emma actively bring her foot towards the floor and at the end, just assist. She doesn't need this exercise, so we're just demonstrating this for if you had a client that did need that. Similarly, if you had somebody who had weakness in TFL, which you're hardly ever going to see, you would have the resistance band over this side and they would be pulling the foot that way. But as we said, because most of us spend probably too long at one time in a seated position, TFL for the vast majority of people is actually going to be short and tight. So I hope you found this assessment, explanation, treatment and home care process useful. We're going to take a few minutes now to do some Q&A, so make sure you get in your questions. Thank you.